The next speaker is Michael Morris from Mercy Medical Center in Baltimore, and he's going to speak about patient-centered in silico assessment of healthy aging, imaging, and beyond. Okay. So, am I the guy? I don't know how to do this.
I can do it.
Okay, you're on.
Thank you so much. Hello. Thank you, Mara, for having me. And my talk is going to be largely clinical. I spend about 80% of my time clinical and about 20% doing research. And the idea of this talk is to give kind of a multidisciplinary audience an idea, an understanding of some of the things that we can do today with medical imaging, and hopefully to inspire you to think about using medical imaging and medical imaging data, because today it really is data, and we're going to talk about that a little bit in some of your research projects, because I think it's a great way to study aging in real people living in a minimally invasive way. So this is my hospital. This is where I work, Mercy Medical Center in Baltimore. We're a private nonprofit hospital right between Johns Hopkins and Maryland. We have a lot of great people there and take care of a lot of patients. Primarily, our hospital focuses on oncology. We have an Institute for Cancer, women's health, as well as liver disease. Our hepatology is very strong, and orthopedics. This is a nice view from our new Bunting Center. It never gets old. And, oh, you cannot? Yes. So this is looking out over Baltimore. So the title of my talk is talked about. These are some of the people that collaborate with us on research activities. Thank you, Dr. Yesha, for having me here as well. So what is the goal of healthy aging research? We talked a lot about lots of different ways, but ultimately, Did I do?
No, it's not.
Oh, here we go. Maybe this thing? Oh, there we go.
There you go. Good.
All right.
Opportunity to give a lecture without slides.
That's right. So if our goal is to extend quality life years, then in order to do that, we need to have management strategies for aging diseases. So a lot of the research that's been talked about over the course of the conference, both here and at the Dead Sea, has been talking about ways to identify those strategies. But really, we need accessible clinical biomarkers. Assessment of these things using medical imaging is some of what my mentor, Dr. Elliot Siegel, spoke about here last year. And in order to develop those, we really need to have an understanding of the pathophysiology. So I think a nice place to start is by the main areas that are causing morbidity and mortality. So if we look back in 2000, a bunch of people have spoke about how we've been dealing with tackling communicable and infectious diseases, and as we've gotten better, the other types of diseases that we see have been the main causes of death. So back in 2000, actually we had a lot of infectious disease up in the top causes of death. But I would just want you to watch, of course, we have vascular diseases, which have always been at the top. And as in the next round in 2016, we start to see, as we tackle infectious disease, oncology, and dementias and neurodegenerative diseases start moving to the top. So why are infectious diseases a problem? Largely, I think today we have good treatments, we have vaccines, we have antibiotics, but still low and middle income countries really struggle to have access to these treatments. And we have some nice organizations now, the Bill and Melinda Gates Foundation, as well as Partners in Health and many others that are focusing on this. And I think that that's been part of the improvement over time. But as you move into upper middle income countries and high income countries, you see that you start to see less red bars and more blue bars, which again focuses on the non-communicable diseases. And right at the top we have neurodegenerative diseases and cancers, and you start to see some other types of cancer moving up. And so my real interest is in oncology, but we can image all of these things. And I'm just going to talk to you about a couple of case studies and then some food for thought for the future and how we can assess aging using imaging. So this is the current one in 2016, as you can see again, dementia, cardiovascular disease, and oncology. So we have lots of clinical ways to studying human aging, questionnaires, blood tests, all of these are great. And I'm going to talk a little bit about how we can supplement those tests with medical imaging data vectors. So this is kind of a topic that I'm pretty interested in. And so we'll start with a case study of vascular disease because I think it's a nice area where we understand the disease pretty well, and we have lots of ways that have been advancing to image it, and we have good treatment for it. So it's kind of a nice place to start as we're thinking about how to approach some of the other diseases. So you can see this is a cardiac catheterization. You can see there's a stenosis here at the left coronary artery, and this is things that we can treat percutaneously. I don't treat them, but a cardiologist does. And then we have more modern imaging using CT, coronary angiography, where we can actually not only quantify that there's a stenosis there, a narrowing of the vessel, but we can say if that's a calcified plaque or a non-calcified plaque, start to better understand the actual underlying characteristics of that plaque, which maybe one day can help us to better understand the actual implications of whether that plaque is susceptible or not. I'm going to talk a little bit about some quantitative imaging techniques because I do radiology and I also do nuclear medicine. And you may know about cardiac stress tests, you may have had one. This images myocardial perfusion, and traditionally we did that with technetium-99 and sestamib, which is a blood flow tracer. And nowadays, more and more, we're moving into PET myocardial imaging. This is using a tracer called rubidium, which is another flow tracer, and we have better resolution these days. And the nice thing about, and we're getting even better with an F18 tracer, which has a higher resolution than rubidium. The nice thing about PET imaging is that it's quantifiable. So we can actually now measure, just like they do with the coronary catheterization, where they can measure the fractional flow reserve and the actual flow in the coronary vessels, we can now quantify even in more segments than the traditional 17-segment model, the actual flow to different portions of the heart. And this is nice because with some of our imaging techniques like the nuclear cardiology in the past, if people had triple vessel disease, for instance, and you're just looking at a relative perfusion, we didn't know if that patient really had sometimes triple vessel disease, which is very serious, could be missed because everything is relatively lower, whereas now we can actually quantify that. And this is just recently being used clinically. We now have a CPT billing code that's separate for quantifying myocardial blood flow to incentivize those people that have PET to use it. And I think more and more we're going to be seeing this having implications in patients that may go for cardiac catheterization. And as I said, we have some good treatments. We can do risk management, medical management for vascular disease. And of course, if patients still have vascular disease, we can treat it with percutaneous techniques and surgical techniques. The patients that do have, ultimately have infarctions, we talked about, they suffer not only the loss of cardiac output, but a lot of times prior heart disease or even cardiomyopathy can cause patients to have sympathetic dysfunction and arrhythmogenic situations where they can have irregular heartbeats that can lead to death, not just from an acute infarction alone. And there has been some suggestion that we can actually image this now. This was a paper that came out of University of Maryland where I trained in collaboration with actually an Israeli company. And they're looking at how we can use, actually image the sympathetic pathways in the heart using MIBG, which is a tracer that follows the sympathetic pathway. In the old days, we used SPECT, but there is a PET tracer that's coming out using F18 as well, which again has the higher resolution imaging and the potential for quantification, which I think will really help to improve how well we can image sympathetic dysfunction of the heart, which has been an area we've had a difficult time doing until now. So really, with cardiovascular disease, to sum up, I think the biggest area to look for in the future is we actually have a lot of treatments. If we know that a patient has issues with their perfusion, we can treat them, we can risk manage them. But the real area where we have is if a patient, we don't know they have disease, they have something very acutely, they can't get to care in time, and they die very quickly. And the problem is really understanding plaques that are vulnerable or not vulnerable. And we actually understand the pathophysiologists of this very well, but we don't have a lot of good ways to actually image it or quantify it, detect patients that actually have these vulnerable plaques other than pathological approaches. So I think that's an area for the future of cardiovascular disease. But it's a nice case study on how if you have the treatment can influence the diagnostics, which can then influence future treatments, which I think is nice. And so in oncology, between 2009 and 2013, we had 20 new drugs approved. We have a lot of new immunotherapy coming out every year. It's a very exciting time to practice oncology. And why do we need so many drugs, and why do we still have difficulty treating oncologic illness despite having all these drugs? I think that the real issue that is a major topic of research these days is tumor heterogeneity. So we know that cancer is not just one disease, it's many diseases, and the problem that we have oftentimes with treating it is that while we can treat some of the cells that are cancerous will respond, others will not, and it actually evolves in your body over time during the course of the disease. And so one of my areas of interest is, can we use medical imaging to better identify tumor heterogeneity? And we'll talk a little bit about that. So we have the cancer Moonshot in the US, which has been driving some research efforts into this area. And I think it's an opportunity for precision medicine, because if we can better identify tumor heterogeneity, then we'll be able to really individualize our care a lot better, figure out what drugs are going to work for which patients and which may not. And so the Institute of Medicine is also very interested in cancer as a potential area for developing precision medicine. So how can we look at the heterogeneity? Well, the heterogeneity really comes from not just the genomics of the cancer, but also the epigenetics, and people talked about methylation, where that comes in, as well as the proteomics and metabolomics. And we can actually quantify a lot of these things in the lab. Many people have and have shown that. But how can we actually use these clinically? Because really our method of obtaining tissue from patients is histopathological diagnosis. It's the gold standard today. But you can't just drill a ton of holes in patients and biopsy everything and every cancer, because, as I said, the cancer actually evolves within one patient. If you have cancer that metastasizes to your bone, it may be different than cancer that metastasizes to your liver. Nobody wants the Swiss cheese t-shirt if they're an oncology patient. We have to be able to image these processes non-invasively. And so I'm going to talk a little bit about medical imaging to evaluate clinical phenotypes. And we talked about medical imaging data vectors. So this is how radiology used to be done, and it's still done in some parts of the world, but I'll say that in most, probably all of the developed world, and actually even parts of the developing world now, are moving away from film-based radiology into digital imaging. And that all started back in 1971 when we started with computed tomography, creating digital images. This is the first CT scan. Some of you guys may recognize it. And this, when we create images using digital approaches, each pixel or voxel that is in that image is actually a data point. It has a numerical representation. So it's not just an image anymore, it's data. And now we practice on the computer, and we can manipulate images and do lots of interesting things. And we have some software programs that can help researchers to look at this data and examine it quantitatively. Here's just a few that I like to use: Amira, 3D Slicer, and Osirix. And you can actually quantify the voxel values here in different CT imaging. You can segment them. This is just an early application of using CT. The Hounsfield unit is the unit that we're actually representing by this image here, where the higher the Hounsfield unit, the higher the electron density, and that's represented by white, whereas the lower the Hounsfield unit, the lower electron density, and that's represented by black. And so in this bone specimen, you can see, you can actually graph those Hounsfield units, and you can create really quantitative models of the electron density of tissues using CT. We don't use this really in our clinical practice that much, but there's lots of opportunities to evaluate this further, and we'll talk a little bit about some of that. Some other simple, these are just a few of my favorite imaging data vectors. So this is a CT with contrast, and we can look at vascular permeability by adding contrast material, which can help us to identify metastatic lesions and other things. MRI can actually image water or fat, so we can, in each pixel, we can quantify the water or the fat content of that tissue. And then we can look at, we can do fancy things like these in and out of phase images. You can see this is actually the liver here, and it gets dark on out of phase imaging because this actually highlights areas where fat and water are interfacing, so this can image microscopic fat. Okay. We can also look at diffusion, and we can look at metabolic activity with FDG, as well as somatostatin receptor expression, which is an area that I'm interested in neuroendocrine tumors. And then soon PSMA will come on the market to image metastatic prostate cancer and other things that can express PSMA. So we used to, in the old days, look at actual Hounsfield unit numbers manually, and up until very recently, we were still basically at this level where we could just quantify the average Hounsfield unit digitally in our PACS system. But more and more, artificial intelligence is an exciting area that's coming into radiology, and there are companies like Zebra here in Israel that are doing some really nice applications to actually analyze this data better and give us more information, as well as this is another company that I enjoyed seeing their exhibits at RSNA this year, Lunit, which uses some explainable AI to actually identify lesions. And Arteris is another company that uses, who's recently had some FDA approvals that are quite interesting to quantify lesions for liver cancer and lung cancer and generate reports, make our jobs a little bit easier. And maybe in the future, when we actually see a medical image, it will come to us with all kinds of data already pre-annotated. Vijay Rao, the president of RSNA, recently this year said that she believes more firmly than ever that AI has the potential to enhance our profession and transform the practice of radiology worldwide, allow radiologists to spend more time on initiatives that will benefit patients and physicians, and that we should embrace AI rather than fear it. So I think this is an opportunity for everybody to join in. I'm just going to touch in the last few minutes here a little bit where I think the opportunities are in neurodegenerative diseases and also precision oncology. So we actually understand, I'll start with Parkinson's disease just because we actually understand the pathophysiology of Parkinson's disease better than some other diseases. You can see that these in the normal tissue, you have these dark cells in the substantia nigra. In Parkinson's patient, you actually lose those cells, and that's, we think, because of these alpha-synuclein proteins that form these tangles similarly to some of the other diseases and cause the death of those neurons. And we can actually image the substantia nigra in MR, but we cannot really tell that much about the clinical prognosis of Parkinson's disease in a patient by MRI with our current techniques. There are some nuclear medicine studies like the DAT scan, which uses a radiotracer that actually images the dopaminergic preaxonal receptors that we can see are decreased in the region of the putamen and remained in the caudate with Parkinson's disease. But unfortunately, this is really only detected late in the disease state after patients are already really having clinical presentations. So it's more confirmatory than prognostic. I think in order to develop new drugs, we really need to know earlier. So there are some new exciting tracers coming out that are PET-based that can also be quantifiable, and there's some new MR techniques as well that are coming out that may help to differentiate Parkinson's disease from some other disorders that can present similarly using radio tracers. And these are just a few of the different types of MR techniques that are being explored. And so transitioning into Alzheimer's disease, we really want to try to detect it in more of a preclinical stage, whereas primarily now we're detecting it after cognitive decline already ensues. This is just using FDG PET to characterize different types of dementia disorders. And we talked a little bit about the neurofibrillary tangles and the amyloid. We have some ways to image amyloid, but again, the most useful type of amyloid imaging that we can do right now with the Fluor beta pair is actually a negative study, has high negative predictive value, but a positive study is not that correlative. So there's some look into tau these days. We can actually have a radio tracer now that's in research and development that can bind to the tau protein, and we can image that, and it shows a similar pattern to the FDG, the areas that are lost in metabolic activity in the later stages of the disease. So that's actually promising for an early detector. This is just an image of that. And so I just wanted to introduce the concept of radiomics, which is an area where I think will help us to better quantify. So we have some of these medical imaging data vectors I've talked about now, but I think there's the potential to develop much more. And so images are more than just pictures, they're data. And I wanted to introduce the concept of spatial data science. And so largely this is actually studied, we talked a little bit about the convergence yesterday at the Dead Sea, and just wanted to mention that actually in spatial data science and geography, we study the idea of different data vectors contributing to the larger piece of the puzzle more commonly than we do currently in medical imaging. And there is some early evidence that suggests that some of this more complex analysis of the medical imaging data can actually distinguish different types of receptor mutations in lung cancer that may have implications for treatment. And there's some work being done in prostate as well. One of the first issues that we have to tackle is the issue of registration, just lining the images up so that we can better quantify that information, and there's lots of tools out there to do that. Then we have to segment the images, which we can do, but right now it takes some time. Then you can actually quantify that segmentation into a virtual biopsy. You can characterize for instance, the CT data, you can characterize the Hounsfield units at every pixel value, and then you can do data analysis on this data. You can calculate these radiomic features. There's lots of different types of features. I'm not going to go over them, but you can calculate about 1,000 different types of quantitative features that we don't currently look at, that we can't actually perceive visually very well. And these features may have implications for diagnosis. So I think that you might think that it's difficult to actually do this in the real clinical workflow, but computers are getting better and better every day, and maybe eventually your coffee machine will be able to do deep learning. These are just some of the frameworks that can be used for deep learning and that we're using. I like Python for some of this as a clinician. It's pretty accessible. There's a lot of opportunities for interdisciplinary research. There's a lot of data sets coming out, and I just wanted to also suggest that the NIH is supporting us with the Image Data Commons initiative, trying to get more medical data available to researchers. I think that the days of siloed data are numbered, and I think that research is going to be a lot better with more open and available data sets. That's something we're trying to promote by creating an imaging data set at Baltimore with de-identified data in medical imaging that we hope will become available as a contribution to the imaging data set soon. All right, and you can do this at your own institution with the research packs. And there's a lot of benefits that can introduce other clinical information into that. And there's a lot of clinical convergent research opportunities that I think are out there. And we'll go from this laboratory of the past to maybe a dry laboratory of the future, and be able to better appreciate some of the details of the imaging data, I think. And so with that, I'll take your questions.
lesson in bioimaging. Okay, one time, I think. Okay, thank you. Thank you.